I'm pleased to say that we have a guest joining us in studio who we spoke with last year on this program. He's kind enough to begin at this early hour and to join us for our entire program today. Dr. Eric Mitchnick is joining us. He is president of Integrated Medical Foundation. We'll find out about the work of the foundation, and we're going to be talking about the topic of prostate cancer in a couple of different ways in our discussion. It's nice to have you join us again.
Good morning, Bob.
And good morning to you. I hope you've been well.
Very well. No complaints.
Integrated Medical Foundation, first of all, how do you describe the entity?
Well, we try to create public awareness, education, and screening for prostate cancer and general men's health, but focusing on prostate cancer primarily. We get out into the community. We have support groups and screenings and educational as well as fundraising opportunities for the prevention, education, treatment of prostate cancer.
Now, one of the things that always comes up in discussions about prostate cancer, I guess it's one of the first things that usually comes up, is about this incidence of prostate cancer. In other words, how common it is. Where are we statistically with that?
Currently, it's 1 in 6 men at some point in their life may be diagnosed with prostate cancer, and in the higher risk groups, it may be as high as 1 in 4 men.
1 in 6 men, but in higher risk groups, it can be
as
more
high
common.
as 1 is 4.
All right, the natural question, and I think I may have asked you this last year, those higher risk groups, is there any reason why those groups are at higher risk, and who are we talking about?
Well, it's especially Caribbean men, but African-American men in general, and then men who have first-degree relatives who are male who also have had prostate cancer are at higher risk. And why? We assume it must be a genetic predisposition because of the hereditary tendency of it. The prevention of it, however, has not been confirmed or discovered yet. It's mostly determining early detection that saves the patients.
Okay. Now, when we're talking about prostate cancer, there's a lot of people who, in the WFAN listening audience, their lives in one fashion or another have been touched by prostate cancer. Some people who are listening to us, they themselves have had prostate cancer or have prostate cancer, or a loved one does have it or has had it. First of all, how do you explain exactly what's involved when we say prostate cancer? What exactly does that encompass?
Well, prostate cancer, like any cancer, are cells that are growing out of control or at their own rate and have the tendency to leave their organ of origin and spread throughout the body. So prostate cancer cells are those type of cells that are originated from the prostate but then change or morph into these non-controlled cancerous cells, and there are more or aggressive or less aggressive versions of those that either multiply and grow or spread at a more rapid rate than others. And the way that they affect your body, obviously, is they affect the primary organ, but they can go to secondary organs and affect those as well.
And when we use this term, the prostate, what exactly are we talking
about? Prostate is a reproductive gland that's located in between the bladder and the penis, and it surrounds the urethra. The urethra is the tube that you urinate through. So the prostate sort of acts like a cork with a hole in it, and as it can get enlarged, it can obstruct that hole called the urethra. And by doing that, it's sort of like pinching off the end of a hose. Makes for urinary difficulties, symptoms, frequency, urgency, a slow stream, all of which may or may not be signs of any problem, because in general, most men's prostate do enlarge throughout their lifetime and then cause some degree of obstruction and or symptoms. The symptoms can be treated medically or surgically, but they're not necessarily a sign of prostate cancer. Prostate cancer most commonly has no signs or symptoms and is simply detected through screening methods, the blood test called a PSA and a rectal exam called a digital rectal exam.
The PSA, prostate specific antigen, that's what it
Correct.
stands for? Okay. See, I've done these interviews, I guess, enough times that popped into my head. What does that look at?
The prostate-specific antigen is a protein that is released by prostate cells, all prostate cells, into the bloodstream and could be detected on a blood test. And it has the ability to be quantified in a certain number. It also has the ability to be separated into a free or a bound form. The general rule is that prostate cancer cells and certain other conditions of the prostate will release more of this protein called PSA into the bloodstream, and then that will be detected on the blood test with a higher number, a higher value. And based on that number, you can then assume that there may be some sort of process or pathology going on with the prostate that may need to be determined. One of those is prostate cancer. And that's where it helps us detect it earlier, because it may be released and found in the bloodstream before it can be felt with a finger on a digital rectal exam.
Now, the digital rectal exam is something that basically, a lot of men have this tendency, first of all, to, as unfortunately I'm sure you know, to fear going to doctors, okay? It's like the last thing that they want to do. And one of the things that they would fear, perhaps even more so than that, is the idea of the digital rectal exam. But relatively speaking, it's over before you even realize it.
Correct. The digital rectal exam is simple, inexpensive, very reliable in terms of detection, and is performed in less than a few seconds, probably 15 to 30 seconds maximum.
And exactly is it that the practitioner is looking for some enlargement?
Well, when you do a digital rectal exam, you're examining the rectal area that a finger could reach. Mm-hmm. The finger could reach and feel rectal tumors, anal tumors, hemorrhoids, mm-hmm. As well as the prostate surface. So when you feel the surface of the prostate through the rectum, it's sort of like feeling the ball of your thumb through the skin. And if the ball of your thumb has any nodules, like a knuckle, then that would be considered an abnormality that you'd want to investigate further. Or if there was an irregularity where it felt more enlarged on one side versus another, we call that an asymmetric gland. That can also be something significant. Or it could feel too soft, which may give us a different diagnosis. So all of those different findings on physical exam will allow the urologist or primary care doctor to say, you need test X, Y, or Z as a further evaluation for your condition.
So that there's not a definite, you have prostate cancer decision made at that
Correct.
time based on that. You
may have a high suspicion of prostate cancer that the detection rates just with the physical exam, where you find an abnormality and then confirm it, are about 1/3. So if you have an abnormality on your rectal exam, only about 1/3 of the time will it turn out to be cancer. That's why the PSA is so essential to aid us, because there are many times where the digital rectal exam is completely normal and the patient has prostate cancer.
The reliability of the PSA test?
Well, in general, the reliability is that if there is an abnormality and the abnormality is not extraordinarily high, in other words, in an area between the numbers 4 and 10, is that the detection rate is about 20% of the time it's prostate cancer. And the detection rate increases if there is, in conjunction with that abnormality on the PSA, an abnormal rectal exam. So just having an abnormal PSA doesn't mean you have prostate cancer, and just meaning you have an abnormal rectal exam doesn't mean you have it. And even if you have abnormal of both, doesn't mean you have it. It has to be proven. And the proving process is the next step.
Now, when we're talking about the incidence of prostate cancer, this is, I guess it's important to state that it's not something that has to be viewed. I'll use a phrase here that often would come up in a discussion like this. It doesn't have to be viewed as, quote unquote, a death sentence.
That's correct. Prostate cancer, once it is diagnosed, is highly curable in the vast majority of the patients. The cure rates for the medium grade, low stage prostate cancer are in the high 90% range, 95 to 97%, with non-invasive methods as well as surgical methods. So there are easy ways to treat prostate cancer that patients shouldn't really fear. If it's caught early, you're going to have a very high cure rate.
We're in discussion with Dr. Eric Mitchnick on our program. He's the president of Integrated Medical Foundation. On the web, the foundation is at imfcares, that's with an s.org. There's a lot to talk about when we talk about the topic of prostate cancer. Now, you mentioned earlier in this discussion, when you were talking about Integrated Medical Foundation, the idea of promoting public awareness and education. I guess, how challenging in a way does that get at times? Because it would seem on the surface that many people at least should have been exposed to news about prostate cancer, but yet some people, some communities just don't seem to have gotten that message.
Well, I think there's a lot of misconceptions about it. There's a lot of negatives that are thought of from it. And the general rule is that if the patient's going to see their internist, they're discussing many topics when they go for their physical exam, not just prostate issues. And we allow them the opportunity to hear their questions and learn about the prostate and men's health in general, so that they can understand what is involved in prostate problems, prostate cancer, prostate problems treatments, prostate cancer treatments, and allow them to freely ask questions at some of our discussion groups, or get screenings that are focused just for men and their prostates, as opposed to a general physical exam, which internists or family medical doctors do.
And then it kind of goes back to something that I alluded to earlier in our discussion too, is this whole idea of men, for the most part, seeking to avoid going to medical doctors and the like. I guess, how can you, in the work of the foundation, kind of address that?
Well, we try to address it in two ways. One is we allow for sort of a discreet way for them to just come sign up for a free screening and get their blood drawn and a quick exam by the urologist, so that there's not all that stigma of waiting in a waiting room, getting nervous while you're waiting, and it's all done anonymous, but they get communicated their results fairly quickly, and there's no cost to the patient. So I guess that's one of the ways that we try to allow them to get past their fears and some of the obstacles that there is to getting diagnosed with prostate cancer.
The other thing is, for them, and I hate doing this because in a way it sounds like I'm stereotyping gender-wise, but some of this is true. Women, for the most part, will talk to one another about things that men would never talk to one another about, especially when it gets to health related issues. That idea of going to your primary care physician and talking about these issues, if you're having some of the symptoms that you alluded to earlier, bringing these things up. How do we go about, I guess, trying to promote kind of an environment where people feel comfortable doing it?
Well, I think shows like this, as well as some of the public awareness that gets put out there on television or in the media, in general, allows patients to open a discussion or start the topic amongst themselves. In addition to the fact that more and more internists or primary care physicians are willing to discuss these different men's health topics with the patients, with that social interaction, patients are more likely to have had a screening, which then they can tell their friends it's not so bad, or they can, give their story about how it felt. We at Integrated Medical Foundation have support groups where patients and or patients' families can discuss in an open forum with a physician or a healthcare professional their questions and issues that come up in a private but semi-open fashion, so that the word gets out about what it is like to go through prostate cancer treatment, what it is like to get diagnosed, or what is it like to be the family member of somebody who's been diagnosed.
Yes, because that's also another aspect of this. It's not necessarily just the patient who's involved in this whole process.
Right. The family is integral in terms of decision making, as well as the treatment and going through the treatment or the diagnosing of prostate cancer. So spouses or children are very involved in the care of the prostate patient, and they can be very encouraging and supportive, as well as integral in making the decisions on how the treatment is going to occur, or how to make the treatment easier, or how to get the diagnosis done. And all of these factors, I think, are important in complete patient care.
When we talk about treatment and treatment approaches, we covered this last year, but I'll ask, because not everybody who heard us then is listening to our discussion now. What are the options?
Well, in terms of prostate cancer treatment, it is very individualized, because there are many options on how to treat prostate cancer, and it depends on the patient's age, grade of tumor, stage of tumor, and state of health as to how that patient may be best treated. So when you look at the prostate cancer patient, you can't generalize like a lot of the newspaper articles try to do. And you have to individualize. So a patient who's 50 and has multiple other cancers or disease states is a completely different patient than one who might be 10 years older or 60 and is in perfect health and works out every day and has no medical problems. And each of those patients may get treated in a different fashion. The grade and stage also plays a major role. Somebody who has got a slow-growing, low-stage tumor may get treated completely different than somebody who has a high-grade tumor who is the same age and in the same state of health. So getting back to what the different choices are, there is a choice called watchful waiting, which means that you watch the cancer to see if it's going to progress based on its current stage and grade. But that doesn't mean ignoring it. It means once every 3 months having a physical exam as well as a blood test to see if it has dramatically changed in the PSA value, and then a once a year repeat prostate biopsy to see if the grade of the cells or what we call the Gleason score, has changed to a more aggressive form. So watchful waiting is not doing an initial treatment, but may require close follow-up for many years, and procedures that are involved that are not totally without its, slight side effects. But it is certainly an option that many patients undergo. Second way that is fairly common is surgery. And surgery comes in basically three forms: open, laparoscopic, or robotic surgery, where you remove the entire prostate gland and then reattach the bladder to the urethra to create a continuous urinary tract again. That is usually for the healthier patient who needs to have the tissue removed to cure the cancer. A third way, which is equal to but less invasive than surgical removal, is radiation treatment. And then there are a fourth and fifth way, which are freezing it or heating it with a variety of methods. But the three standard ways that are most commonly used certainly would be watchful waiting, surgery, and radiation.
Freezing it?
Freezing it is called cryosurgery, where you basically place probes in through the skin into the prostate to freeze the tissue. And then heating it is through an intense wave of heat energy that penetrates through the skin to heat the tissue, all with the idea of destroying the cells without having to actually remove the cells. The radiation treatment obviously is the standard form of doing that.
So how, in the case of the freezing or heating it, how long would that be? I mean, is that something that's... It's
a one-time treatment. And the negative to it is that there aren't long-term studies on these newer forms of therapy. And they tend to, at least in the beginning, have more side effects than the standard forms of care, which would be radiation and surgery.
And when we talk about the side effects, what are we talking about?
Well, mostly urinary side effects. That's the most concerning to most patients. So when somebody has their prostate treated, because of its location, like we discussed before, in between the bladder and the urethra, they can have urinary symptoms or side effects. So the simplest ones are frequency and urgency or slow stream, which can be handled usually with medications. The more difficult ones to solve would be what we call urinary incontinence, where the urine comes out when it's not supposed to, when you wanted to keep it in. And those are much more common with the surgical procedures than they are with the radiation procedures. And they're more common with the freezing or the heating procedures as well. Of the 5 different major forms of therapy, watchful waiting and radiation have the lowest incontinence rates.
When we talk about research and leading research in this field, where is that taking place?
Well, I think there's multiple centers across the country, but they're throughout wherever prostate cancer is treated in high volumes. And cancer centers, radiation centers, all have done many studies on the different forms of prostate cancer, and there are innumerable papers that come out every month on prostate cancer treatment results and side effects and long-term management therapies and how they work and what the pros and cons are of them. And I think that the problem with all of the research for prostate cancer is that it takes a long time to have accurate data because of the natural history of the disease and in the age population that the disease occurs in. So until you have really 10 or 15-year data, it's difficult to determine which form of treatment is going to be better than another.
And when we're talking about the research approaches, is the leading research specifically in this country? Is there leading research in other countries?
I think it's worldwide, but a lot of it is in this country.
Okay, because I guess we also have a tendency in this country to wonder how it is that we compare to other countries when we're talking about the incidence of prostate cancer.
Well, there are certain pockets around the world that are higher than the U.S., but we, obviously, because we have a very good healthcare system, we detect it a lot and get to treat it a lot. We also live longer than most countries.
It gets back to that whole idea, too, of early detection, all right, and the importance of that. Dr. Eric Mitchnick is in studio with us. He's the president of Integrated Medical Foundation, and we're talking with him about the topic of prostate cancer and the work of Integrated Medical Foundation, IMF Cares, that's with an S.org, a very comprehensive website. There's a number of things that we have not mentioned thus far in our discussion. I want to get into talking about the Blue Ribbon Run, which is upcoming in a couple of months as well. But there's a word that you used earlier in discussion that I want to follow on, because it was one of the thoughts that I had heading into this discussion today. And that's this idea of prevention, and prevention when it comes to prostate cancer. The question, Dr. Mitchnick, is what do we really know about prevention? What kind of steps can be taken? What sort of things do people try?
Well, right now there's no definitive prostate cancer prevention. Unlike cancer prevention with other disease states or with heart disease, where there are definitive ways to treat a number or a condition before it happens. With prostate cancer, we're basing it on some data and dietary changes and demographics that we're looking at, which may or may not have an influence on it. So the general rules are a high fiber diet that's lower in fats and proteins is probably, and the word is probably, healthier for the prostate than one that's high in fried foods or proteins. Certain antioxidants may have an influence on protecting the prostatic DNA. So there's been certain research on some things like lycopene and selenium and vitamin E and D have all been looked at in terms of cancer prevention, but there's no definitive thing that says if you take this or eat this or do this, that you're going to lower your incidence of prostate cancer. Unlike, let's say, with heart disease, where if you don't smoke and you exercise and you take cholesterol-lowering medications and you eat a healthier diet and you're not obese, you're less likely to have coronary disease. It's not like that with prostate cancer as of yet. I think there'll be probably more and more genetic research that's getting done, just as there are many new prostate cancer drugs that are out there that we're using for the later stages of prostate cancer. That in the last 2 years, there have been 4 major new avenues to treat the end stage or later stage prostate cancer when it's no longer curable, but you're trying to extend that patient's life by either months or years. And we've made major strides in that area currently, and that's been dramatic, as a matter of fact.
When you say that this is to prolong the patient's life, what exactly do these medications do? Well,
when cancer is beyond the cure stages, where it has spread, and you have used your usual first and second line treatments to try to either rid the patient of the cancer or just control it, prostate cancer is controlled through hormonal manipulation. The cancer grows in response to the male hormone testosterone. Mm-hmm. We know for many, many years, probably 70 years now, that if you take away testosterone from prostate cancer, it tends to slow growth. It may even shrink up to the point where it's virtually undetectable. But it won't cure the disease long-term forever in every patient. So there are many patients who eventually, if they have prostate cancer and it has spread and have been treated with anti-testosterone treatment, become what we call hormone refractory. In other words, the cells don't care whether or not there is testosterone around or there isn't. So we continue to keep them in a hormone state where they have low testosterone. However, we want to offer them something that will continue to keep the cancer from spreading. So there have been 3 or 4 different avenues that have come out over the last 2 or 3 years that have really made a major improvement. One is immunotherapy with a drug called Provenge, which is basically like a vaccine against your own cancer, where we take cells from the patient and then process them in a way and then infuse them back into the patient to allow for shrinkage of the cancer. And it actually has been proven to extend patients' lives. Another way is to manipulate the hormones through oral medication within the cells of the hormone refractory prostate cancer. And by doing it, by not just stopping testosterone production, but by actually manipulating the prostate cancer cells themselves with these new drugs, we've again been able to extend life. And a third way recently is also tagging cells with radioactive materials that can be then given to the patient by a simple injection, which again will extend patients' lives and or get them out of pain when it spreads to their bones. So there have been major strides of the end stage of prostate cancer, but still the goal for all of us is to treat it when it's an early stage so you can cure it and not end up in those end stages.
When you were mentioning lycopene and selenium and vitamin E and vitamin D, I also wanted to ask you then, because this always comes up in these discussions too. Saw palmetto is often mentioned. First of all, what is that? And secondly, is there validity to what is said about it?
Well, there are many herbal supplements that are used for prostate symptoms. None of those herbal supplements has been proven to either A, really relieve symptoms in double-blind randomized trials. In other words, where the patient and the doctor don't know what they're getting, and then they take symptom surveys to prove whether or not the herbal supplement worked. So all the claims that you might hear for different prostate supplements may have some value, but none has ever been proven in using scientific method to actually have value. There are other herbal supplements in addition to saw palmetto, like stinging nettles and several other herbal concoctions of plant phytosterols that are used, all of which may have some impact on the prostate itself. However, none has been proven in that sort of scientific method that it does work. And the variety of theories are that it may have a hormonal base that it works on, either blocking what would make the prostate grow or actually decreasing testosterone within the prostate cells. There's no actual studies that have proven how these things work or if they work. But many, many patients do try them, and many patients do get success with them. So the jury is still out.
The idea of the support groups that are offered through Integrated Medical Foundation, how key are they to the work that you do?
Well, I think the support groups are instrumental in allowing the patients to make educated decisions, because they often will hear one point of view when they see a given urologist. Mm-hmm. Whereas when they go to a support group, if there's 20 patients, they're hearing the opinion of the 20 different urologists that those patients may have seen, plus whoever is leading the discussion may be able to give them answers that they were afraid to ask their own urologist. So I think that the support groups are very influential and important for the patients to attend to make a decision. At times, they're sometimes confusing for the patient, but I think more often than not, they get more information out of a support group than they do about asking, their relatives or reading something on the internet or in a newspaper on how they should treat or not treat their prostate cancer. And because that one person that told them is just their one experience, when they go to a support group, they're hearing many people's experiences as well as their doctor's information from many patients. So it's sort of a way to gather a lot of information in one hour session.
All right. You used that word internet. Many people get a lot of information online. In some cases, it's very valid information. What about the rest of it? Because there's a lot of information out there about prostate cancer. And how do you, I guess, discern what's valid and worthwhile versus the things that you want to steer away from?
Well, I think any information is good as long as you know where the information came from and you can understand or interpret the information. So the problem that sometimes the internet has is that it doesn't explain the information well or completely, or the person who's reading it doesn't understand the explanation or doesn't understand the information, and they just focus on one fact that they pick up. So, and also whoever is writing it may have a particular bias. It's not necessarily unbiased information. Mm-hmm. So there's so much information out there that you can obtain through web searches or even library research that without the interpretation of an expert like a urologist is difficult to sometimes interpret.
I alluded earlier to an event that is upcoming in November of this year, the Blue Ribbon Run for Prostate Cancer. What exactly is involved with that? And this is the run and a health exhibit.
Right. Well, we have annually 2 runs. One is in the spring at Belmont, where we kick off the Belmont Stakes Week at a run at Belmont Racetrack. And the other is in Long Island at Syosset Woodbury Park. This November 17th is our new run that's coming up. And any runner is from amateurs who want to just walk the course to real professional racers are involved. And patients can get information there, but more importantly, we can raise funds for our support groups and free screenings and education and awareness that we do with our foundation by having runners and sponsors participate in our run.
And if folks want information on that, they can go through the website?
Yeah, that's probably the best way, is to go through the website. You can actually log on and register on the website through our links. Greater Long Island Runners Club also has links to our run. So we have a lot of ways to find the run, get to the run, and we have great participation.
IMFcares, that's all as one word, .org, the website. We are in discussion with Dr. Eric Mitchnick on our program. He's president of Integrated Medical Foundation. We're talking about the topic of prostate cancer and the work of Integrated Medical Foundation. You know, you alluded to exactly what was coming up with the November 17th Blue Ribbon Run for Prostate Cancer and Health exhibit. Events like that, where you get out and are in the community. Why is that important? How is that so important to getting the message out that you're trying to reach people with?
Well, I think in a friendly venue like a running event, people can come up, ask other people questions. There's plenty of physicians there. There's free screenings at the events many times. There's informational pamphlets. So it's in a an environment where people don't have to be intimidated or frightened by the physician and can get information about prostate cancer or even be screened.
And it's important as well to, I guess, be able to have those kinds of events in as many different communities as you possibly can, too.
Yeah, we try to have our screenings throughout the New York metropolitan area. We do the events through many different communities, and the events attract a wide geographic area to allow patients, their families, friends, learn a little bit about prostate cancer and help a good cause.
What we'd like to do as well in this portion of our discussion is try to work in some thoughts from some of the people who are listening to us. Some of them have been waiting very patiently for this opportunity to jump in with a thought or a question. WFAN's toll-free line, 877-337-6666. It's brought to you by Mohegan Sun. Visit Margaritaville at Resorts Atlantic City, now open. And I'll tell you what, let's start with folks on the phone because one gentleman has been waiting for what must seem like forever in Woodbridge. Jay, good morning. Thanks for waiting so long.
Oh, Bob, thank you for taking the call, Doctor. Thank you so much.
Actually, it's Woodridge where you're calling from. Okay.
Yeah, we get the mail mixed up here, too. This beautiful little town we have here in Bergen County. Doctor, I got a little bit of a problem going on here. I'm 66 now. At the age of 50, I probably had my first prostate exam. At that time, my prostate number was 1.5. The prostate was small. Doctor says, good to go. He says, we'll check it again along the way. And it stayed that way for, up until probably, 63 years old. I knew I was having a problem with testosterone. During that, from the age of 50 and 66 now, some of the meds I've been on is Coreg, Metformin, Vytorin, and they just recently added Januvia. Okay, so I went to the urologist with this testosterone problem that I thought I had, and sure enough, it was low. I don't have the numbers in front of me.
Right.
All numbers. The two numbers were low, very low, and the total low off the charts. He said, I'd like to start. Gave me a couple shots during the, a week at a time.
Right.
And then he also prescribed for Testa,
right,
the gel. So we used the gel for about 2 months. Went back and checked the numbers again, and the 1.5, 1.6, 1.7, for the 10, 13 years, doubled, went to 3 while using the Fortesta.
Right.
Which he said, well, we got to watch that being that it doubled. He said, it's really not a high number. He said, the prostate is still small. And at that time, he wanted me to continue with the Fortesta. I was a little bit leery about that. I didn't want it to go from 3 to 6. I was starting to have quite a bit of urinary problems at night. So then he prescribed Rapaflow. Well, you know what the Rapaflow does to you.
Yes.
Okay. So at this point, I don't know what to do. I have canceled 3 appointments with the urologist who have the pellets implanted for the testosterone.
Right.
What do you think about the testosterone pellets?
Well, they're an excellent way to replace your body's lack of production of testosterone.
Okay.
You really have to be committed to it because it's going to last for 3 to 4 months at a time. So once those pellets are in, you don't want to be in the position where you're not sure about treating your low testosterone.
Okay.
As far as the prostate symptoms are concerned, you could change to a medication that doesn't cause the side effect that you're concerned about.
The number going up, you mean?
No, the Rapaflow.
The Rapaflow. Yeah, I'm not using it anymore, the Rapaflow.
Okay. The number
I'll deal with it 3 times a night,
Well, there is a medicine that doesn't have that side effect that can be prescribed. It's a very similar drug. It just doesn't happen to have that one particular side effect.
Okay.
It's called Alfuzocin.
ALFUS?
OZIN.
OZIN, okay.
And that works identically to Rapaflo without the side effect that you're concerned
Wonderful, wonderful.
of.
That other, the other side effect.
Yeah.
Rapaflo. Okay, that's. I wonder where that goes.
Yeah, into your bladder. But you just have to be very closely monitoring that PSA.
The PSA.
Because a doubling is of some concern, but it may level off at that number. But you should be, probably monitoring it again in 2 months.
After the pellets?
Yeah, because you don't want to see that, go over the number 4 and, trigger a concern for prostate cancer.
Right. Now, how long do you think them pellets last the first time, doctor?
Well, they can last anywhere from 2 to 6 months. It depends on how fast your body metabolizes them.
Okay. And then I would have to continue with the pellets.
Well, you can always switch methods. You can go to the injectables that you had in the beginning. Mm-hmm. You can use any of the topicals. They come in different brands and patches as well.
Right.
And then the pellets. And you don't have to stick with one method. You can always go back to a different method that you were happier with.
Okay.
So the only negative to the pellets is that once it's in you, it's not coming out for 3 or 4 months.
It's not this, yeah. And do you see any major side effects with the pellets?
No more than you would with the other forms of testosterone replacement therapy.
Okay, just the number probably could go from 3 to 6.
Well, that would be, with whatever method you used.
Yeah.
That PSA could go up if there is a minute focus of prostate cancer.
And then pellets, they release at a certain point. They
dissolve and then they wear out, basically, like any other medicine.
Hey, doctor, thanks so much.
You're welcome.
Really wonderful. I really appreciate it. This is the best information I've had in years.
Oh, you're welcome.
Thank you so much for being on the show.
Thank you very much for joining us on the program.
Thank you. Bye-bye.
Interesting discussion. The two of you talking there, it almost seemed like it was two colleagues talking because you're throwing these terms around of all this different medication. I guess because patients get so involved in what they are being prescribed in their care that they become quite knowledgeable on the topic themselves.
Yeah, if they are involved and educated and instructed by the urologist and pay attention to what they're taking, they can learn enough that they can figure out what they like or don't like about a certain treatment plan.
Interesting discussion with Dr. Eric Mitchnick on our program on the FAN this morning. What we're going to do is try to work in some thoughts from as many folks listening to us as possible. Let's see if we can get a question in from our next caller here before we take a pause. John in Lyndhurst has been holding for some time. John, good morning. Welcome to the FAN.
Good morning. Thanks for taking my call. Doc, just a quick question. I'm 45. I had a cystoscopy a few months ago. Swollen middle lobe. PSA 1.74. Doctor, before surgery, prescribed me J-Lit.
Right.
I've been taking. Any thoughts on, of course, you were talking about reading stuff on the internet. Some people say 3 to 6 months. I am type 2 diabetic, which is controlled with meds, and I do still experience some frequent urination. My flow is better. But there are just times where, maybe the J-Lin is not working yet. I know when you're trying to shrink some tissue or an organ, it can take a while. Any thoughts on that?
Well, J-Lin can take up to 1 full year to have its full effect. However, it may not, even at 1 year, give you the satisfaction that you desire. Urinary frequency is a difficult problem to solve, especially nighttime. So the flow is the easiest for us urologists to help you with. I wouldn't give up yet on the J-Lin. I would probably continue with it for at least a few more months before you switch to a different modality.
But he wanted to do the TERP. At my age, he said maybe not such a good idea because I might need it again in 10 years.
Right.
And, there are, as you know, everybody that's researched this knows there are a lot of side effects. it's just, I was just curious if you'd seen anybody have good success with it, or is surgery the final option for, cleaning out that lobe?
No, a lot of people can have success with medication. I think you should be patient and stick with it a little bit longer.
I do take salt palmetto, too. I heard your discussion earlier about, some of the natural stuff doesn't work. I mean, could that be hindering it from...
Yeah, I probably would stop it if you're on the Jalin.
Really?
Yeah.
Okay, because, people that sell the herbal supplements, they say, use this in addition to your medication, you're going to see faster, quicker results.
Not with this particular one. So,
really?
Yeah, there's a component to the Jalin that may interact with the salt palmetto, so I would probably stay away from it.
Interesting.
All
Thank you very much.
John, thank you for your call and your patience on the phone this morning. We'll try to get to some more folks as we continue. The topic is prostate cancer. Let's go back to the phone. Let's see. We're headed out to Rob in Lake Success, who's been holding for some time. Rob, good morning.
Hey,
Thanks for holding.
Good morning to you there, my friend. Doctor, I happen to be a physician as well, so I have a little more knowledge, I guess, than most of your callers, what you're going to respond to me. My question is on testosterone. You had a wonderful call earlier on the gentleman who was asking all these different questions. I'm in my 50s, low testosterone as well, and I tried it a few years ago, the gel testosterone, the way it was, it was prescribed to me. Didn't like the idea of having to do it for the rest of my life. Now, I tried it. I'm very highly athletic, distance runner, so I'm very, do a lot of jarring to my body. And, concerned about possibly calcium levels being low and getting injuries due to that, stress fractures, as well as the low testosterone. I'm trying to stay off testosterone my whole life. What are the potential, what could happen to me if I stay away from it? I know the side effects are high levels of, you can increase the chance for prostate cancer, high blood pressure, things like that. That's why I'm trying to stay away, and I don't like the idea of having to do it for the rest of my life. What are my options? And let me hear what you have to say, doctor.
Okay. Well, the pros versus cons argument for testosterone replacement, depending on who you read, most of the times the pros outweigh the cons. So the lack of testosterone usually will have a higher incidence of osteoporosis. There'll be a higher incidence of endothelial damage to your microvasculature. There's obviously a higher incidence of impotence. There's a higher incidence of depression and a higher incidence of obesity. So all of those are the things that testosterone will probably help you with. Testosterone replacement therapy has not been shown to increase the incidence of any cancers. As long as you monitor your blood work and don't go super normal, you usually don't have the elevated red blood cell counts that you can have. You usually won't have elevated liver function tests. You may have a slight increase in prostatic symptoms, but there's never been proven any increase in prostate cancer incidence. You may have some increase in snoring or muscle soreness, but usually that's not significant. So the pros outweigh the cons. Obviously, you're putting a hormone that isn't there back into your body and not doing it in super normal levels. The topicals have a variety of pros and cons. The pro is obviously you're getting a small amount of it every single day. The con is you do have to prescribe it, apply it, make sure it doesn't get on anyone else. And the transdermal or through the skin mechanism varies from company to company. So some work much better than others in an individual. And it's not one is definitely better than another. It's that one may work better in one person versus the next. The pellets get around that by getting in the subdermal tissue in the adipose layer, so you don't have to worry about that transdermal mechanism of the gels or the patches. So I hope that alleviates some of your fears and answer some of the questions. You can't eliminate all the negatives. Like with any drug, it's the pros and cons and the risks, rewards that you get out of it.
Dr. Eric Mitchnick is talking with us on a program on the Fan. Sports Edge follows our 8 o'clock update. Rob, I hope that answered the questions that you had raised for the doctor. Thank you for your call this morning. One thing we had not mentioned thus far in our discussion, we've only got a couple minutes left in our program. My goodness, it doesn't seem like we just started this show.
Yeah.
This does whip along, this program. There is an event that's coming up at the end of this month. Wear Blue for the Men You Love and networking cocktail party. What's involved in that?
Well, September is Prostate Cancer Awareness Month. We try to bring out the awareness of prostate cancer and men's health. And one of the events that we're having is a networking, I'll call it a cocktail hour, at a place in Babylon called Monsoon, which is being run by our organization, IMF Cares. And we're trying to just bring awareness of prostate cancer through this fundraising event. It's a nice event. It's a sort of to sum up the month, a way to get people to think about prostate cancer. And hopefully next year we'll have Wear Blue all month, not just that one night.
And it's a way, obviously, for getting women involved in the whole discussion, too.
Yep, the spouses are invited, and we're looking forward to a fun event.
Dr. Mitchnick, you have shared an awful lot with us in this discussion. IMF Cares, that's all as one word, .org. Very comprehensive website. There's a lot of information there. They cover some of the things that we have talked about in our discussion. I thank you very much for taking the time to come in and join us. It's nice to see you again. We certainly wish you the best with the organization and with your upcoming events.
Thanks, Bob.